learning about us for the first time through this town hall webinar. We are a network of more than 60 healthcare, housing, and social service organizations, along with city and state government partners, really working to strengthen and integrate the healthcare and housing systems. And we do this work in a few different ways. We provide trainings and resource development to frontline staff to really equip them with the information and resources that they need to be able to serve their clients and patients who have health and housing needs. We also put on different cross-sector events to bring people together from across different organizations, industries, to meet one another, build relationships, learn about resources. So we offer quarterly interagency case conferences to bring people together to be able to talk about complex cases. We have usually about 2 a year housing marketplaces to learn about new housing vacancies for different populations and what the eligibility is, how to access them. So really trying to get that information to you as frontline staff working on housing for your clients and patients. And we also hold a health and housing convening every year in December. And that's where we really talk about the salient issues happening around healthcare and housing and homeless services. We also do advocacy and research. We have, for the past 7 years, conducted a hospital homeless count, which is the only count of its kind in the country that sends volunteers into hospital emergency rooms on the night of the city's annual census of the streets and subways to survey people who are homeless in hospitals on the night of the count and really understand what their needs are and who the city is missing by not including hospitals. So those are just kind of a sample of some of the work that we do. Please visit our website if you want to learn more. We've been doing a lot recently to support our members and kind of the larger community in New York City, service community, and amongst amidst the COVID-19 crisis. And so we've been doing these town halls. This is the 4th in our series of town halls. We've had representatives from the Department of Homeless Services and Health and Hospitals discussing the protocols for hospital referrals to DHS isolation sites. We had a town hall with the New York City Emergency Management to learn about the OEM isolation beds and how to access them. And we also had a town hall with a medical expert, a doctor from Janian Medical Care, who specifically works with the homeless, just talking about and answering questions about the novel coronavirus and COVID-19 and how to protect your clients, patients, and yourselves working on the front lines. So this is a continuation of that series. We want to continue to support frontline workers with by providing information and how things are changing in this new environment. So we have 2 speakers today, from Erica Basco from the Bureau of Alcohol and Drug Use Prevention, Care and Treatment at the New York City Department of Health and Mental Hygiene, and Dr. Andrew Sugoshi from NYU Grossman School of Medicine and the New York City Health and Hospitals Virtual Buprenorphine Clinic. And I'll let them introduce themselves in just a moment. Just a bit of housekeeping before we dive in. We are going to be sharing an evaluation towards the end of this webinar, and we really encourage you to fill out that evaluation. It's an opportunity for you to give feedback on this town hall and what information was helpful and what we could do to improve them. And it's also an opportunity for you to give feedback to us on what else would be helpful. We're going to be continuing to do events like these and making them available to our larger network. So that's really helpful feedback for us to know what it is that you need so that we can respond accordingly. After each of our presenters speaks, we will have a Q&A. And so how that's going to work is you all can type your questions into the chat box as you think of them as we go through the presentation. And we will be sorting those on the back end. And then I will read those questions aloud to our presenters. So just to kind of make sure that this is organized, so you'll all remain on mute for the duration of the webinar and through the Q&A. So really type those questions into your chat boxes and we will hopefully get to all of them. Any that we don't, we will try to share with our presenters and maybe we can get responses to you after. We will be able to post, we're recording this session, and we will be able to post that on our website and share it with all of you, as well as the presentations and some resources that will be mentioned during these presentations. So all of that will be shared with you and posted on our website. I think that that's all of the housekeeping items. So with that, I'm going to hand it over to Erica.
Green, and hope that this works. Okay.
Yeah, okay. We got your presentation.
All
Perfect.
Good?
Thanks, Erica.
Thank you. So my name is Erica. I work at the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment within the Department of Health. And I'm going to give sort of a broad stroke view of substance use during the COVID-19 pandemic. So here's the outline. I'm going to give a little bit of contextual information about how substance use, as well as the services dedicated towards substance use, have shifted due to the pandemic. And I'll also take some time to talk about the responses from the health department in terms of recommendations and guidance around substance use for alcohol, certain service programs, harm reduction promotion, as well as talking a little bit about how treatment has shifted. And hopefully I'll have enough time to drill down on a new methadone delivery system that the health department has implemented. So the COVID-19 pandemic has shifted how substance use occurs, where it occurs, and when. And it has also impacted the way that substance use related supports and resources are provided. So the pandemic has impacted everyone in New York. And some of those impacts are related to isolation and physical distancing, related to sudden losses of income or growing economic precarity, and barriers to resources and material needs. Recent health opinion polls that the city has conducted indicate that New Yorkers are experiencing increased anxiety, increased probable depression, and above average financial stress. The result that we are concerned about is a potential increase in chaotic substance use and coping with substances, alcohol, and drugs. The COVID-19 impacts people who use drugs in specific ways. People who use drugs may have underlying health conditions that increase the risk for severe illness. New York City, along with other municipalities, also have an aging cohort of people who use drugs, baby boomers. Also, some housing environments, such as congregate settings, encampments, shelters, housing instability of any kind, make it difficult or impossible to follow COVID-19 prevention measures, such as staying 6 feet away from others, washing hands with hot water and soap. Also, social distancing measures may increase the risk of fatal overdose as more people are using drugs alone in their home or wherever they use drugs. There have also been disruptions in the drug market. We've heard this a lot from SSPs. So unstable drug markets, i.e. Unreliable sources of drugs, can increase the risk of withdrawal and also contribute to chaotic drug use. This is compounded by increases in anxiety, depression, and economic precarity. And again, we're worried about an increased risk of overdose. I'm sure many of you know what syringe service programs are, but just to give a little bit of context, they're programs that provide immediate services to people who use drugs, such as sterile syringes, Hep C and HIV testing, care coordination, food, groups, etc. And what we're hearing from our 14 contracted SSPs across the city is many are experiencing staff shortages, a lack of PPE, a lack of soap and hand sanitizer, which have limited program operations. Limited program operations have limited the supply of sterile drug use equipment and naloxone given out to people who use drugs to engage in SSP services. And this may result in an increase in bloodborne infections such as HIV and Hep C, as well as fatal overdose. Also, HIV and Hep C virus testing services have been suspended at some SSPs. So this is a lot and seems bleak. I wanted to also highlight some responses that the city has implemented. So one way is we've created a lot of guidance and documents to the public. So we recently released an alcohol-related guidance that acknowledges that substance use, specifically alcohol use in this case, may change as a result of the pandemic. Folks may be drinking more often, drinking more alone, or drinking more in terms of the actual amount as a result to cope with stress, anxiety, boredom in relation to the pandemic. The document is understanding and not judgmental, but also provides mindful drinking strategies. And these strategies would be great to provide to participants or patients. So they're take note of how much and how often you drink alcohol, space drinks over time and alternate with food and water, and avoid mixing drugs such as sleeping or pain pills and alcohol as it can lead to overdose. The document also provides information on additional supports if people feel like their drinking is negatively impacting their life, and provides links to treatment. We've also created a harm reduction guidance for safer substance use, safer drug use. And we've adapted some existing overdose prevention strategies to the realities of COVID-19. And they are stock up on naloxone and sterile drug use equipment such as syringes. Avoid using alone, but maintain physical distance with people you're with. We know this is tricky. And if you're living with others, create an overdose safety plan. So this involves disclosing that you are using drugs and having naloxone visible before you use. The document also provides COVID-19 prevention strategies, such as use disinfecting products and wipe down packing supplies and surfaces before use. Prepare your drugs yourself. See if your local SSP is able to deliver sterile supplies, such as syringes and naloxone. And if you inject drugs, avoid sharing works, such as syringes, cookers, cottons, tourniquets. And if you must share works, rinse supplies thoroughly if you're using and do not wet the needle. If you use pipes, bongs, straws, or e-cigarettes, avoid sharing and use an alcohol swab to wipe the parts that touch your body. We do a lot of work with syringe service programs, and they have been adapting to the realities of COVID-19 as well. So the State Department of Health considers syringe services an essential service. And in response to hearing from participants, syringe service programs are distributing additional safer drug use supplies per interaction, and also increasing their food distribution and pivoting towards more grab and go items. Some changes vary across SSPs depending on the location and their capacity, but include suspension of in-person groups, reduced services and hours, and most BUP services are continuing virtually or in person, and many can add new participants. In response to hearing from many of our SSPs that we contract with that they lack PPE, we recently secured masks, non-latex gloves, hand sanitizer, sanitizing wipes, and garbage bags to our SSPs. The masks are for staff and SSP participants. We're also conducting regular check-ins and release operational guidance, which is online. Treatment has adapted as well. So for inpatient and residential treatment, physical distancing protocols should be used, and they include keeping some beds available for sick participants. Hoteling options are also available for participants who get ill and can't from COVID-19 and cannot isolate safely in their own home. Hotel options are also available for healthcare workers to reduce the transmission risk from home to office or clinic. There's also a COVID-19 staffing portal that allows programs to hire new staff in the event of staff shortages, which we've been hearing is an issue. For outpatient treatment, most of the providers that we contract with have fully transitioned to remote telehealth, including telephonic services. So this includes intake, psych assessments, groups, etc. If on-site services such as detox are clinically indicated, social distancing protocols are being followed. We have heard that there are some barriers preventing participants from engaging fully in treatment, and that includes growing financial support needs and also not having consistent access to a phone. I'm going to just quickly gloss through this because Dr. Sagoshi is going to be talking more about this, but for BUP, buprenorphine treatment, telemedicine can now be used for BUP induction and prescribing as of March 31st, and I'll leave it to him to talk more about that. I'm going to talk a little bit more about methadone. So methadone and BUP are the gold standards of treatment for opioid use disorder. Decades of research show that methadone is safe and effective to use as treatment. And despite its effectiveness, methadone is the most regulated medication in the country. It's highly regulated and only available at specialized clinics called opioid treatment programs, OTPs. And with few exceptions, participants have to go daily to get their methadone dose, which means that they may experience withdrawal if they miss a dose. Currently, anyone with COVID-like symptoms unrelated to a pre-existing health condition must stay home. This poses a problem as New York City has a large methadone population. Almost 30,000 people in New York City are engaged in methadone treatment, and over half are ages 45 and older. As a result of sort of barriers to accessing methadone for many of participants at OTPs, there have been some federal shifts. So on March 16th, the DEA permitted doorstep delivery of methadone to people in quarantine or in isolation. Also, SAMHSA now permits methadone programs to provide medication under blanket exception. So they're allowing up to 14 doses for clinically less stable patients and up to 28 doses for clinically stable patients. New York State Office of Addiction Services and Supports has also provided additional guidance about dosage. So with these sort of changes in federal regulation, as well as the challenges that the pandemic presents for methadone access, the health department developed a methadone delivery system and recently started implementing it. So we're currently working with OASAS to deliver methadone to existing methadone patients at DHS isolation hotels and at people's homes. MDS is expected to expand to other isolation and quarantine hotels, including the mock J hotels in which folks recently released from Rikers, as well as upstate prisons are staying. And the eligibility criteria is currently for people who are existing methadone patients and are COVID positive or experiencing COVID-like symptoms, or are ages 65 and older, and have a chronic health condition and have an OTP willing to provide a minimum of 14 days of medication for home and 7 days of medication for isolation hotels. We are discussing about lowering the age requirement, and also just in general, OTP medical directors can refer patients at their discretion.
Hi, Erica. Apologies, sorry to interrupt. And a number of people seem to be having trouble hearing you. I'm wondering if you wouldn't mind speaking a little closer to your mic if possible.
That's okay. Yeah, I can.
Okay, thank you.
No problem. So the program works in that OTP medical directors at licensed OTPs identify eligible patients. We at the health department then receive the names of the patients through the OTPs and OASAS, and we fulfill the request. A courier and a driver team pick up the methadone doses from the OTPs and then deliver it to the patients in their homes or in isolation or quarantine hotels. The methadone arrives in a lockbox for safekeeping, along with a naloxone kit just in case. And the program is beginning to scale up a lot more. So just to provide some concluding thoughts, the pandemic is affecting and will continue to affect substance use in the way that people use drugs, as well as the way people seek services for substance use. The health department and the provider systems that we contract with are working to create continuity of treatment and support during the pandemic. And what we're just asking is that people spread the word about methadone delivery, the resources we provided in this talk, and treatment options to help connect people to care. It's really important right now, as I'm sure you all know. And then the last page is resources, which will be uploaded along with the other slides. So that's it.
Great, thank you so much. Are you there, Bonnie? No, sorry, I wasn't sure if Bonnie was still there. Thank you so much for that great overview, and particularly the focus on methadone. And now, and if people have any questions about Erica's presentation, please go ahead and put your questions in the chat box, and we'll collect those, and we'll get to a Q&A at the end. And for now, Dr. Andrew Sugoshi from NYU School of Medicine and the Health and Hospitals Virtual Buprenorphine Clinic is going to talk. Thank you, Andrew.
Great, thank you. Thanks so much for having me, and thanks everyone for joining. So I'm actually about to finish med school in a week, and I'll be starting residency in primary care, and my background was in addiction medicine, and I aim to do that going forward. So today I'll be talking about the virtual buprenorphine clinic. I'm going to try to share my screen. Just let me know if there's issues. All right, is this set up okay?
Yeah, that's perfect.
Great. Sorry, I'm just going to scroll back up here. So some of this will be a little bit redundant with what Erica spoke about. I think I started with a little bit of background on opioids and medications we use, and then I'll talk a bit more specifically about our clinic that we're starting up, or that we've been running. So in terms of a brief overview of opioids, I'm sure this is familiar to most of you, but basically they're binding through receptors in the brain, and the systemic effects are this kind of pain relief and euphoria, and then alongside with that, a decreased respiratory drive, and that's usually what our big concern is when people are overdosing. It's just they stop breathing. And of course, when people become dependent on opioids, there can be a severe withdrawal syndrome associated with that. Usually it's not fatal in and of itself, but it can still be incredibly unpleasant and causing things like anxiety, stomach upset, insomnia, muscle cramps, sweating. People generally feel pretty miserable. And then in terms of medications for opioid use disorder, so the first line treatment are these things we call medications for opioid use disorder, and refers to things such as methadone, which Erica spoke about, as well as buprenorphine, extended release naltrexone, and there's also now buprenorphine extended release. And for treatment of an acute overdose, we use naloxone or Narcan, which I'm sure most people are familiar with. And in terms of buprenorphine itself, it is a partial agonist opioid medication, meaning that unlike most other opioids, you can't actually overdose on it. It won't ever affect someone strong enough to fully stop their respiratory drive. It's most commonly taken as this buprenorphine naloxone combination known as Suboxone. This can be taken as a pill or sublingually as a little strip that dissolves under the tongue. And people often have preferences. I've heard varying stories from different people on why they love or hate different formulations. And historically, it can only be prescribed by physicians who have undergone training to receive this waiver. And it requires frequent outpatient visits and check-ins. And there's also limitations in terms of how many patients a doctor can prescribe. And now I'm going to talk a little bit about the intersection of opioid use disorder and COVID-19, also similar to what Erica was speaking about. So obviously there's been decreased access to care insofar as a lot of the outpatient clinics have closed, including those at Bellevue, which is where I've been at. And likewise for in-person support groups and therapy meetings, a lot of those have been suspended. So some of them are now happening virtually, but we don't have the same kind of support groups that people were able to do before quarantining. And then lastly, for individuals who may struggle to have a phone and may have trouble finding a place to speak privately or to engage in these meetings now that they are in different, socially isolated positions, and especially for the homeless people who are in shelters, it can be hard to find access to places to have these conversations. And then in terms of this population, prior to this pandemic, we were already seeing this rise in opioid use and overdose in the last decade, exacerbated most recently by fentanyl, which is just being found in every kind of all kinds of street drugs, even non-opioids have been found to have fentanyl in them. And opioid use disorder can worsen individual COVID-19 outcomes insofar as it does reduce respiratory drive, which on top of a respiratory illness would not be great, obviously. And then of course, social isolation and disruptions to harm reduction and addiction treatment services and overwhelmed emergency rooms are unable to refer to individuals to care for these issues, basically. So as Erica mentioned, in response to the COVID-19 guidelines, or the response to COVID-19 is that the Drug Enforcement Agency and the Substance Abuse and Mental Health Services Administration have broadened the prescriber flexibility amidst the pandemic. So I just have this quote here with SAMHSA strongly recommending use of telehealth or telephonic services to provide evaluation and treatment of patients. And these resources can be used for initial evaluations, including evaluations for consideration of the use of buprenorphine products to treat opioid use disorder. All right, and that brings me to the virtual buprenorphine clinic, which we have set up running out of Bellevue currently. So just in terms of a little background and timeline, so March 12th, 2 months ago, was when we had this temporary halt in new outpatient-based opioid treatment patients. March 17th was when the virtual buprenorphine clinic we started planning meetings. A lot of the physicians running it began meeting to set it up. Then on March 20th, everyone was ordered to stay at home, and on 25th, we became operational and started seeing patients. So in terms of who we serve and what we do, so we are offering services to anyone in New York City seeking continuation or initiation of buprenorphine treatment for opioid use disorder. For people who are currently out of state, we will provide care if they have been seen at a health and hospitals facility within the past year. And we work with individuals on medication-assisted treatment transitioning out of Rikers. So if people are leaving Rikers and they've been maintained on opioids or opioid treatment at Rikers, they can be linked to us so that we can continue to provide care. And we will take any patient, regardless of insurance or ability to pay. We have a social worker and staff that's willing to help people either sign up for Medicare or work with their insurance as needed, or Medicaid rather. So we do not offer methadone or Vivitrol, but we do prescribe Narcan. So for almost every patient who we're prescribing buprenorphine to, we're also offering to see if they have access to Narcan and advising them to pick up Narcan along with their buprenorphine prescription. And we can refer patients for additional needs, especially for a lot of the needs surrounding patients from lower socioeconomic backgrounds who might not have access to stable housing or even phones. So we are doing a lot of referrals to either primary care physicians, mental health resources, assistance with housing and phone access, as well as free legal aid. And one other thing with primary care physicians is that a lot of the primary care physicians, at least at Bellevue, often are being called in to work inpatient now. So often there will be like laps where they'll have a different physician covering for them, and sometimes patients aren't able to navigate that. So we have been helping with that as well. In terms of who we are, so the virtual buprenorphine clinic is comprised of full-time waivered providers. This is physicians and nurse practitioners who can prescribe buprenorphine. We have a social worker who can assist in managing a lot of the insurance coverage issues, as well as any other like directing patient towards additional resources across a whole range of issues that they might have. We have a clinic coordinator who's tracking all our patient appointments, ensuring patients' medical needs are being met adequately. And then we have student volunteers who are involved heavily in the in-between and missed visit follow-ups to try to improve retention and also just address any emergent issues that might pop up between visits. And our hope is that those in-between calls will also actually improve retention in the clinic, which will hopefully lead to better patient outcomes overall. So in terms of the workflow of the clinic, so when someone is joining us, it's pretty straightforward. First, when they call into the number, which we'll provide after, we have our clinic coordinator just do a basic demographic intake, ask them about their access to phones, and if they need any immediate needs in terms of phone access or help with insurance, we can try to start addressing that at that point. And then they're given an appointment time. And so then they would call in for their first visit. This is an actual physician encounter. Ideally, we do video if patients can do it. For some people, if they can't, I think there's certain criteria where we can do it without video. But this first visit is basically your standard physician encounter visit. They would ask all your basic questions. Obviously, there's not any urine toxicology going on at this time, just because we can't, because it's virtual. But otherwise, most of the time, the first visit is just understanding where the patient's at, and then trying to get them their prescription for buprenorphine if they are eligible and need it to be continued or initiated. And then after their first encounter, we have these between visit follow-up check-ins, and these are the volunteers who are calling in and mostly just asking questions about if they've had any access or trouble with getting access to their medication, if there's been any emergency room visits since their last appointment, and if there's any other concerns that we could help with. And then from there on, we have regularly scheduled follow-up visits, which I think varies by patient need and acuity. So in terms of the results and how the clinic's been doing so far, so we've had, I think since we started up, about 1 to 3 new patients daily. In terms of the demographic characteristics, about 22% were recently released out of jail or prison in the last month. 22% are actually not mobile phone owners, so we've been trying to assist them in getting them access. And then 20% are undomiciled. And in terms of clinical findings, we've had so far very high active enrollment post-induction, so our retention rate is stronger than it was with the outpatient clinics. Hopefully part of that is due to just the ease of having one single clinic number that they call into when there are issues. And hopefully the follow-up calls are also helping with that. About 21% we've referred to intensive outpatient programs, and about 12% have been referred to primary care. So in terms of going forward, so we make it clear to all our patients that this is a temporary solution, so it's only meant to provide short-term care with the goal to transition patients to long-term maintenance therapy at one of their many clinics at health and hospitals or in the community, pretty much based on their preference. So they know that the setup we have going now is not, we don't anticipate this being indefinite, but we do at the same time hope this model can demonstrate efficacy in addressing opioid use disorders using this telehealth modality with an eye towards expanding access and care to this population going forward. Because I think if we can show that telehealth is an effective way to manage certain patients with opioid use disorder, then that could lower a barrier that, which is the obvious barrier of just having to go in every day or go in every other week to a physical place. And this is our flyer. And pretty straightforward. I guess our number's on the bottom, but hopefully I can either find a way to send this out or distribute it for anyone who is interested or knows anyone who could potentially benefit from these services. And that's it for me. So thanks everyone for listening.
Great, thank you so much, Dr. Sagoshi. All right, we will get started with Q&A. Thank you to those who sent questions in advance and those who've been entering your questions into the chat box. So we have some questions that are for Erica and some for Dr. Sagoshi. So I'm gonna kind of group them so that you all can kind of get through them, and then we'll move on to the next. So, so for Erica, for those who receive methadone in a lockbox, how is it opened?
So the OTP gives the patient a code, and there's a code on the lockbox for them to unlock it.
Okay, great. And Erica, just so some people were having a difficult time hearing you, others were hearing you fine. But if there is a way for you to maybe speak a little closer to your mic, that might be helpful to the ones who are having difficulty.
Okay.
Thank you. Okay. Are there any, also for Erica, are there any additional overdose concerns for patients having access to 14 days of medication available?
Yeah, I can answer that. So of course, like that is a concern, and partially why we include a naloxone kit in the lockbox. We also know and are making sure that OTPs are regularly checking in with patients through telemedicine. Most are checking in daily.
Okay, good. Have there been any changes to the prescribing process of medical marijuana?
To my knowledge, no. Though I would probably prefer to do a thorough dive of the research before definitively answering that. Yeah.
Okay, so maybe we can circle back with that one.
Totally.
Okay, all right, now a few questions for Dr. Sugoshi. Wondering what your team does for phone access referrals, and also about phone access for clients who do not have phones or minutes.
Oh, sorry, I had to unmute myself there.
All right, you're all good.
Can you hear me? I'm good.
Yeah.
So we actually don't know the specifics on how we're referring. We have a social worker who's largely rocking out with most of this in terms of getting access to people who don't have phones. I know we have had some patients who have had intermittent access to phones that have still been able to get into their appointments. But in terms of how we're getting people specific phones, I don't personally know that, but I can look that up for you and get back to you on that.
Okay. And on that point, I see some people in the comments have been sharing resources. So let's see, Lifeline. So Michelle Hennessy says, Lifeline has a list of all the telecom providers throughout New York State that provide free phones. If you don't have it and want it, please email me at mhennessy@liberty.mgt. So that's in the chat box for those, and we can maybe send that around. Thank you, Michelle, for offering that service. Another service mentioned is Assurance Wireless, can help with phone services, which is one under the Lifeline program. Okay, great. So just a little additional information there. Thank you. Someone asked, wondering if there was someone from Assurance that your team had partnered up with rather than the online application process. I don't know if that question makes sense to you, Dr. Sugoshi.
I'm sorry, what's it in regard to?
Maybe this was a question for somebody in the chat box. Okay, yeah, I'm going to skip that one. Okay, so these are just general questions. So, if whoever wants to jump in, what local inpatient or residential treatment programs are still operating during the current pandemic?
I can provide a list to the group tonight. Do you want it to be Bronx specific?
Nope, that's, we have people from mainly the Bronx and Brooklyn, but I think there's folks from all over the city. So whatever you have citywide would be great.
Okay, I can get that, yeah.
Thank you so much.
On our end, we do have I'm not sure if that's exactly the question, but we refer, so for people who we feel that just the buprenorphine clinic itself is not providing enough support, we do have more intensive outpatient services at Bellevue. There's the CDOP, the chemical dependency outpatient program, which is outpatient, but now they're having more kind of intensive like therapies that you call into. So it's still virtual, but it's a bit more of a full kind of regimented program than our clinic.
Okay. How do you judge a person's behavior via telehealth as it relates to triggers?
Well, I think it's generally pretty difficult. I think as Erica mentioned too, she might have better insight, but it seems like we just, without having, the inpatient, especially because everyone's personal living situation has changed so much and now there's all these additional stressors going on, it is hard to kind of fully isolate that often, especially if it's only a telephone call, but hopefully with enough speaking to, and we are doing kind of motivational interviewing as our interviews go on. So we're hopefully trying to identify those triggers and try to work with people as, they're adjusting to the new normals.
Do you have any advice for, other folks who are now doing kind of telehealth or tele-case management, for the first time, in how to pick up on some of those behaviors and triggers?
I think in terms of speaking, I don't know if there's any one specific thing I would say. Definitely, I think in my own experience, video is definitely more helpful than, doing just purely on the phone, but getting a better sense of the person's environment and just trying to understand how the social determinants, of everything going on has impacted them is usually a good starting point, because most of the people who we've talked to, for some people I've spoken to, they've actually said, oh, this actually quarantine self-isolating has been beneficial to in some ways, just because I'm now in a more supportive, like I'm in a house now and I can't leave my house and I'm with family or whatnot. So that's actually been helpful. Whereas for other people who are undomiciled or maybe now quarantined in a, in a situation that's obviously or like more stressful for them, or more conducive to using, that can be a huge trigger. So I think just getting a sense of their environment is where I always start.
Erica, did you have anything to add?
No, Dr. Sagoshi, I think covered it. It's, a learning curve.
Great. Any advice on strategies for engaging clients living with substance use disorder during COVID-19?
I'm sorry, could you repeat the question?
Any advice on strategies for engaging clients living with substance use disorder during COVID-19?
I mean, I think just like acknowledging that this is an unprecedented time and that, feelings around panic, anxiety, economic scarcity are completely normal and expected, I think is important. And also, I think that there's been a huge push around telehealth, but also trying to meet folks where they're at in terms of doing a traditional phone call, for example, and acknowledging that folks might not be able to meet appointments as regularly because of a lack of privacy.
Yeah, I think really coming at it from, meeting them where they're at, I think is the most important in terms of just trying to not, like at least with our own clinic, we have, of course, guidelines where, if a person is, say, like selling their Suboxone or whatnot, we want honesty, but we don't want to be punitive on our end because we want to ultimately just try to help people as much as we can without trying to make them feel like dealing with us is an added pressure rather than a support.
Are there any specific resources for helping link people with these services and services specifically for undocumented patients?
So there is a resource in calling NYC Well. Calling or contacting NYC Well, you'll be connected with somebody who can provide information about accessing services and concerns around immigration status.
Do you have any pointers for helping someone transition out of opioid dependence while still doing pain management for chronic pain?
I mean, I think that's a really, really hard question all the time, especially if part of the opioids were being used for pain management. Current guidelines right now, specifically on the opioid end, is that we don't really know if there is an ideal time to like stop. So say you're being maintained on Suboxone and that's also adequately controlling your pain, then often it's hard to kind of come at that with like a mindset of like, I'm going to take this for a short amount of time and then I'm going to stop, then deal with the pain separately. Even just on the opioid use, and our current guidelines suggest if the Suboxone is working or the Methadone is working, to continue with that rather than like looking towards an endpoint. Though that said, I know people often don't like the idea of being maintained on any kind of opioid treatment for long term. Sometimes people just find that like an uncomfortable place, but with chronic pain especially, I think it's really difficult for those patients. I do think that a lot of more basic, I'm sure this has been suggested before, but kind of mindfulness techniques, doing more kind of low level physical activity, depending on what the issue is, kind of like classically medical techniques, like those can, I think, help a lot and are often underutilized. But for people with chronic pain, it is often just difficult to control the pain while also trying to come down on opioids if those are a part of the pain management.
Yeah, so I just got to follow up that specifically there's talking about prescription opioids.
So they're prescribed opioids for pain and they want to?
I believe so.
Yeah, I mean, so it's hard. Sorry, like I think it definitely will vary patient by patient in terms of the very specifics. So definitely that's something worth talking to their personal physician about, because yeah, if the opioids are adequately managing pain, then obviously stopping that is going to leave you now with this pain that we want to try to control with other means, which can involve these non-medication techniques that maybe help to some extent. But if there's still an additional need for some medications, there are of course other non-opioid pain medications. But whether or not that's going to perfectly control someone's pain, it's always hard to say. So yeah, it's unfortunately really dicey, I think, trying to come down off of a baseline opioid medication being used for pain, just because of both, if you've been on it and have physiological dependence, then obviously the withdrawal from that and kind of slowly tapering down, but then you don't want to leave the pain unaddressed either, because it's of course unhealthy to live with pain all the time. So yeah, I wish them the best of luck with it. It's definitely a hard position to be in.
Thank you. How long would you advise, oh, sorry, Erica, did you have anything to add? Oh, okay. How long would you advise for a telehealth during COVID-19? I think maybe like the duration of the visit. But Janet, correct me if I misinterpreted.
Well, so I mean, our intakes are usually so pretty straightforward. So we the first intake call, which is kind of basic demographic, that doesn't take long. The first actual visit, I think we allot, I want to say 45 minutes to an hour or so, and that's doing the call with a psychiatrist or primary care provider who's working with the clinic, and then in between then we have the follow-up phone calls. Those usually last. I mean, obviously we cater to what people can manage, but usually anywhere from, I would say, 5 to 20 minutes, depending on how in depth a person's issues are. And then follow-up appointments generally tend to be shorter, but again, it varies by patient. If they need to go longer, they can, but usually about half an hour, I'd say, for follow-up visits, just to make sure everything's okay.
Thank you. Well, I think if you have any more questions, please keep sending them in the chat box. And just to let you know about a resource that was shared, Montefiore is offering primary care and buprenorphine treatment through telemedicine during COVID-19, including patients discharged from detox, rehab, jail, etc., to initiate or continue treatment. So that may be another resource, and it looks like someone just put into the chat box the phone number for the Montefiore virtual buprenorphine clinic in the Bronx, in case that's more convenient for anyone.
And I think Bonnie, Janet had a follow-up question about telehealth.
Oh, thank you. Okay, has telehealth been working, and what tips to keep clients engaged?
Yeah, I mean, I think that thus far, at least in our experience with our clinic, again, we need to, because we've only been running this for less than 2 months, we'll see how it goes going forward, especially we'll see how long these guidelines last and what goes on with social isolation policies and whatnot. But thus far, we've had really good retention. And I think part of that is due to just the kind of simplicity of having one clinic phone number that people can basically call for all their needs regarding their buprenorphine or Narcan access. And then we also have these follow-up calls with student volunteers, which are hopefully keeping patients engaged, but also allowing them to bring up any issues they might have to kind of just provide better care, which will hopefully reinforce them to keep coming. So far it seems like it has been working. Obviously, I think, there's ups and downs to telemedicine for sure. I think lowering the barrier to access is always good, but obviously it's not exactly the same as an in-person visit. But in terms of keeping clients engaged on our end, we've just tried to come at it with this, very kind of harm reduction mentality of if there's need and we can help that, we want to facilitate, treatment in as open environment as possible and trying to improve access to care.
Yeah, and to just piggyback on that, I mean,
Oh, Erica, I think your video froze. Okay, it seems like we're having
You know, some anecdotally, we've heard that some programs are.
Erica, I'm so sorry to interrupt, but you're we lost you for a chunk of that. So if you wouldn't mind starting over, that would be great.
Just trying to meet people where they're at. We've heard from some programs an increase in telehealth engagement and some barriers. So I think in a few months we'll be able to sort of to say more about trends.
Great, thank you. There was a suggestion in the chat box that as people have been kind of sharing things, that we can absolutely compile the different resources that are being mentioned. And if you are aware of any others, or you specifically have a program within your organization that you want to share, you can email those to Harmony, and we can kind of put that all together and share as well. Okay. All right, we'll give just another minute for any last questions.
Also, just thanks so much for compiling those resources, especially even like the phone call thing that was brought up in terms of access to phones will be super helpful. Even aside from virtual buprenorphine clinic.
Great, glad to help you. Okay, yeah, Harmony just provided her email address in the chat box that you can email if you know of any resources that you want to share. Give it just another minute. Harmony also, while we're waiting for any last questions to come in, shared the link to the evaluation. Normally when we have these events in person, I will stand at the door and not let you leave until you give us an evaluation. That's how seriously we take these and your feedback. The consortium from our very beginnings 9 years ago have just done work in response to what's been helpful and what we hear from folks on the ground. So it really is important to us to get this feedback from you. That's how we decide what work we're going to do, what our next topic will be on these town halls. So this is my standing at the door, barring your exit, plea to please complete those evaluations for us. It's pretty short. It's not too cumbersome.
That's what I was told. I'll show you what I was told.
I'm not sure who's speaking. Okay, it looks like, all right, I don't see any more questions, so I think, yeah, please.
Bonnie, I just want to, one person, a lot of people said thank you, that this has been great. Somebody said more, please fill out the evaluation and let us know what more specifically you're looking for. For the people who are asking where you'll be able to get a compiled list of the resources, as soon as we have everything put together and on our website, anybody who registered for this webinar will get sent an email with a link to our website where you'll be able to find all of these resources, both the slides, a recording of the webinar, any resources that were mentioned during the webinar. We'll compile all that and send out an email. But yes, please, if there are other things that you would like to hear about that you think would be helpful, please fill out the evaluation and let us know what those things are so we can get planning.
Great. Yes, thank you so much to Erica Basco and Dr. Andrew Sugoshi. We really appreciate your time and sharing your expertise. I know things are really intense right now, and you know, we appreciate you lending your time to us, and really thanks to everyone that's, you know, working on the front lines of this crisis and you know, putting yourselves at risk, your families. I know that you are sacrificing a lot, and the least that we can do is to help get you connected to the information that you need and resources. So, you know, thank you all so much. Complete that evaluation and have a great day. Thank you.
Thank you so much, Bonnie.
Thank you so much. Take care, everyone.
You too, thanks.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.